Good evening, everyone, and a very warm welcome to this, our first webinar of our new Bone Matters series on medication support. I'm Rose, and I'm the Head of Information Support here at the Royal Osteoporosis Society.
And I'm Sarah, and I'm a specialist nurse and clinical advisor at the charity, and together we're going to be hosting the session tonight.
So Bone Matters is our new series of online information sessions where we're going to be posing all of your questions about osteoporosis to experts through a series of videos, Facebook Lives, and now webinars. And we're delighted to be joined by so many of you tonight. I can see we've got more than 200 people on the session, which is absolutely fantastic, joining us live. And in this session this evening, we're going to be taking a close look at drug treatments for osteoporosis. And we hope you're going to come away from the session with a much better understanding of these treatments and feeling more informed to make decisions about your medicine.
Yeah, so we're going to be talking, as Rose said, about drug treatments for osteoporosis. So that's the bone strengthening medications, because we know it's a really important topic for many of you. And we're also aware that there are still a lot of uncertainties and confusions. And this often means that starting or continuing with your osteoporosis medication can be quite difficult sometimes. However, we hope that with good information and good support, you'll feel better informed and be able to come to decisions that feel right for you. So we have received lots of questions already, and we're going to do our best to cover as many as we can in this session. So let's start off, and I'm going to start by introducing our speakers today. You will have already received a full biography in the emails we have sent you, and very exciting to say that all three speakers are expert in this field. They're consultants and medical doctors looking after people with osteoporosis and prescribing the medications that we're going to be talking about. So they're really well placed to discuss this topic. First, we're going to have Dr. Nicky Peel, who is chair of the Royal Osteoporosis Society Clinical Committee, and she's going to be giving a short live presentation all about the range of drug treatments that are available for osteoporosis. Then we're going to have Dr. Zoe Paskins. She's going to give a short live presentation on how decisions are really made about who needs an osteoporosis medication, both by professionals and by their patients, hopefully. And then thirdly, Professor David Armstrong, who sadly can't join us this evening, but has sent a pre-recorded presentation. We're going to share that with you, and he's going to start answering some of the questions that we have received. And then at the end, quite importantly, we're going to have 20 minutes at least for questions and answers with a panel that both Dr. Paskins and Dr. Peel are going to sit on. And I'm going to be posing either the questions that we've already received, but really importantly, looking at those questions that you're going to be popping into the Q&A box, and we're going to answer those if we can. So before we get started, we would like to do a quick poll and find out just a little bit more about you, our audience, and your experience with osteoporosis medications. And you will see popping up on your screen 2 questions with the option for you to select an answer and submit that to us. Now, don't worry if you can't fill it in. You don't have to. It's not essential, but we would love you to try. The first question is about whether you're currently taking an osteoporosis medication. And then we've got a second question asking you how you feel generally about osteoporosis medications. So I'll just give you a moment to read through and give us your response if you can.
Great to see all the answers flying in. Thanks, everyone.
Okay, so how are we doing? Can we see something about the responses? Aha. So great and interesting, in fact, that though a huge proportion of you are taking a medication for osteoporosis, we are also seeing, in fact, 61% telling us they do have some uncertainties. So I guess that tells us that this webinar is really important. And hopefully we're going to move you along a bit and answer some of those questions and make you feel more comfortable. So that's a really interesting poll. So thank you very much for.
Thank you, everyone, for sharing where you're at with us. It's really interesting to see the mixed results and the different perspectives that people have on their medications. So before we kick off with the first speaker, I just need to run through a few housekeeping issues with everyone. So first of all, questions. We asked all of our members to submit questions in advance of this session, and just thank you so much for all of those. We've been looking very carefully at each of those questions, and for much of them, it's really helped to shape the content of the talks that you're going to be hearing this evening. And then we've also selected a few of the most frequent questions that we're going to put to Dr. Paskins and Dr. Peel after their talks today. And then, as Sarah mentioned at the end, when we have our panel Q&A, that's where we're going to be taking questions that you're asking us live this evening during the webinar and selecting from those to pose to our panel at the end. So if throughout the webinar today you have a question that you would like to ask, we ask that you please input those into the Q&A box at the bottom. So you should see that at the bottom of your screen. So just pop any questions that come up in there and we will take a look at those very carefully. So please don't put questions into the chat, but the chat box is where you can communicate with the other people on the webinar, chat and post comments. That's absolutely fine. Unfortunately, we are not going to have time to answer every question that is asked today, but we have lots of information about medications and treatments on our website, including really detailed fact sheets on each of the medicines. And we also have our specialist nurse helpline, which is there if something isn't answered today. We're going to be posting some links to all of that in the chat. So a few other housekeeping pieces. This session is being recorded, just to remind you, and that recording will be made available to our members first of all, and then after a few weeks it will go up on the ROS website for everyone to see. So everybody is off camera and on mute, so everyone watching and participating. So that's how we're going to operate the webinar today. If you want to say anything, you can post comments into the chat section. But just to reassure you that nothing that's posted in the chat or in the Q&A will be visible on the recording, so that won't be seen on the recording afterwards. We do have a member of the team who's monitoring the chat box, so give them a shout if you have a problem with anything. We're a little bit limited in the technical support we can offer in a webinar like this, but we will do our best to help if we can.
Yes, and finally, just to say that we would at the end like to hear your feedback about the session, because it's the first one that we've hosted like this, and we would like to improve what we're doing for events in the future. So we'll be posting a link to you with a little survey. It's really short and just take you a few moments to fill in. We will email it to you after the event as well. So thank you. And right, let's move on. I'm sure you just want to get on now and hear more about the drug treatments for osteoporosis. So I'm hugely delighted to introduce our first speaker tonight, Dr. Nicky Peel. Dr. Peel is a metabolic bone specialist working in Sheffield, and she's going to be introducing you to the range of osteoporosis drug treatments. So welcome, and over to you, Nicky.
Thank you. And could one of you just let me know if my slides are up and look the way they should do?
That's great.
Perfect. Thank you. So let's move things around on my screen a little bit so I can see what I'm doing. So good evening, everyone. I'm really pleased to be part of this webinar, and it's great to see so many people have joined us this evening. So I'm going to talk about the drugs that we use in osteoporosis. I'm going to cover the range of treatments available. I'll try and answer questions we're often asked about how the different types of treatment work, how they compare to one another, and why we might recommend different treatments for different people. And I'll also talk about what's new, which is really exciting, as it's more than 10 years since we last had a new treatment. But if we're going to understand how the treatments work, we need to think about how our bones work. So that's where I'm going to start. It's easy to think that our bones are, well, just sort of there and not doing very much. But actually, our bones are pretty amazing and very complicated. So they obviously provide support, hold us up. They also protect the organs inside. So think about the skull and the rib cage. They allow us to move around. Bones also have an important role in storage. So, for example, calcium is needed in many places in the body. And it's essential that the levels of calcium in the bloodstream are kept within a really narrow range. And this is made possible because the bones act as a kind of reservoir, taking in and releasing calcium as it's needed elsewhere. And another thing that you may not be aware of is that the bones are where all our blood cells are made. So in order to be able to do all these things, the bones have to be strong, but light enough not to slow us down. They have to be able to interact with and respond to the other systems in the body. And they need to be able to repair themselves from everyday wear and tear. And also if we have a broken bone or an operation like a hip replacement. And all of these things are possible because of something that we call bone turnover. So bone turnover is the key to understanding bone health and what can go wrong with it. It describes a cycle in which tiny microscopic amounts of bone are removed and replaced. And during the cycle, bone is removed by cells called osteoclasts. This is called resorption. And then other cells called osteoblasts move into the cavity, and they're responsible for the formation phase. They lay down the scaffold of the new bone and the calcium and other minerals which finish off the process. And this is a cycle, is a continuous process going on in many, many places throughout our bones and throughout our lives. About 10% of all our bone is renewed in this way each year. And the whole process is very coordinated. The cells communicate with each other and they work in harmony. And changes in the balance of this bone turnover cycle are responsible for changes in the bone. So what I'm showing here is that the amount of bone that is removed or resorbed is in balance with the amount that has been formed. And this allows tiny cracks and stresses in the bone to be repaired, but the overall amount of bone doesn't change. And this is the situation that we see in healthy bones, for example, in a younger adult. Now, in this example, I'm showing what we see in children when the bones are growing and changing shape. So here, the balance is in favor of bone formation, with more bone being built than has been removed. This, on the other hand, shows the opposite scenario, with the balance being in favor of resorption and more bone being removed than can be replaced. And in this scenario, there is bone loss, and this can eventually lead to osteoporosis. There are two components to bone loss which can lead to osteoporosis. So one is imbalance, which I've just described, with too little bone being formed to replace what's been removed. And this occurs with aging and in response to things like steroid treatment. And the other is high turnover. So this involves an increase in the speed of the bone turnover cycle, which results in more places where bone has been removed and an overall decrease in the amount of bone. And this happens, for example, in women at the time of the menopause, and can also be either caused or made worse by diseases that are linked with osteoporosis. Bone loss makes the bones more vulnerable to fracture, firstly because bone strength depends on the amount of bone, and secondly because bone loss damages the intricate structure inside the bone, making it more porous and weaker and more likely to break. And all the treatments that we use in osteoporosis work by altering bone turnover and affecting this balance. So the treatments that we use the most are what we call anti-resorptive drugs. And these all work by reducing the ability of the osteoclast cells to remove bone. So they slow down bone turnover and reduce the imbalance. They can reduce the amount of new damage that occurs in bone, but they aren't able to repair damage that's already built up. They also lead to small increases in the amount of calcium laid down in the bone, and so they can result in small improvements in BMD or bone density. And this group of treatments includes the bisphosphonates, as well as Denosumab and HRT. The second type of treatments are what we call anabolic or bone-forming drugs. These have their main action on the osteoblast cells and lead to an increase in bone formation. They can repair some, although not all of the damage to the structure of the bone, and they tend to produce bigger increases in bone density. And the main treatment in this category is teriparatide, which a lot of you will have heard of. And a similar treatment called abaloparatide is available in some countries. And I've put it on the slide because NICE is going to be considering this later in the year and considering whether it can be used here for some types of osteoporosis in men. And finally, we now have a new treatment on the horizon that actually works in both ways. So in other words, it reduces bone breakdown and at the same time increases bone formation. And this treatment is called Romosozumab, and I'll explain a little bit more about it in a minute. So I want to look now at these groups of treatment in a bit more detail and think about who might get which treatment and why. So many people will start with one of the anti-resorptive treatments, often with weekly alendronate tablets, or in younger women, maybe with hormone replacement therapy. And the starting point for treatment is often driven by cost and what our guidelines say. But the really important thing to understand is that there are a range of treatments. So if the first one you're given doesn't suit you or doesn't work so well, there'll almost always be an alternative that you can have instead. And these are all effective treatments which prevent further bone loss and reduce the risk of having fractures. But because they can't reverse damage that's already occurred, these treatments tend to be most helpful for people with earlier or less severe osteoporosis. And in this situation, they can keep the condition under really good control. And we know that tablets don't suit everyone. So, for example, they can sometimes cause side effects like heartburn, and people with memory problems can find the instructions quite difficult to follow. So issues like this can often be overcome by switching to an injectable form of treatment with either zoledronate, which is given once a year, or Denosumab, which is given every 6 months. And a lot of people ask questions about these injectable options and wonder if one's perhaps better than the other. And the first thing to say is that they're both really good treatments, and they do what they say they're going to do. And the research shows that they both reduce the risk of fractures by pretty much the same amount. There are some minor differences which can influence the choice between them. So, for example, some possible side effects are a bit different. And zoledronate is often given at a hospital visit, whereas Denosumab can often be given at the GP surgery. But the main difference between the two is in how long they work for. So zoledronate wears off really slowly, which is why it can be given just once a year and sometimes even less often. On the other hand, Denosumab injections wear off very rapidly, and this treatment must be given on time every 6 months. It's really important to know that if Denosumab injections are stopped for any reason, or even just if they're given late, that all the benefit that's built up during the time on treatment is lost within just a few months. And this can be a real problem, particularly after treatment for a few years, as this rebound effect of rapid bone loss can undo all the benefit and has been linked to the occurrence of spine fractures a few months down the line. And this rebound is quite difficult to manage and prevent. And because this makes it hard to stop Denosumab treatment, we tend to avoid using this in younger people, and we would generally prefer zoledronate in that situation. So moving on to the anabolic treatments, these are particularly useful for people with more severe osteoporosis because not only do they build new bone, but they can also repair some of the damage in the structure, and this makes them really effective. So teriparatide can be used in both men and women. It involves a 2-year course of daily injections. These are usually self-administered, so it's quite a commitment. People often feel quite nervous about giving the injections, but it's actually rarely a problem in practice. Romosozumab is only approved for use in post-menopausal women at the moment. And this involves a monthly injection, again, usually self-administered, and this is given for 12 months. Both of these treatments wear off very quickly when the course is finished. So it's really important to have follow-on treatment straight away with one of the anti-resorptive drugs to maintain the benefit. And if you're wondering whether these treatments would be even better if they were used for longer, the answer is probably not. So the big increases in bone formation that they cause are temporary and actually start to decrease even during the later part of the treatment course. Unfortunately, both of these treatments are quite expensive, so they are less readily available. And we've learnt over the years that this type of treatment is most helpful if it's given as the first treatment instead of after treatment with an anti-resorptive drug. Up until now, this hasn't really been an option for most people, but fortunately that's going to change with the introduction of Romosozumab. And I'm sure many of you will be wondering whether the way that Romosozumab works makes it better than all our other treatments, and also whether it might be available to you. So it certainly is a very effective treatment, and it's been proven to be better than alendronate in preventing fractures in women with severe osteoporosis. It's also been shown to cause larger increases in bone density than teriparatide given over 12 months. But that's actually a bit of an unfair comparison because the full course of teriparatide is for 2 years. And it's still unclear whether Romosozumab is actually any better than teriparatide in preventing fractures, but they're both very good. And in terms of availability in the UK, Romosozumab was approved for use in Scotland and Northern Ireland about 18 months ago. And NICE have provisionally approved its use in England and Wales. We're just waiting for the final guideline to be published, hopefully any day now. Treatment can be considered for postmenopausal women who've had at least one previous fracture and who have severe osteoporosis, and in whom there are criteria showing that they are at imminent risk of having further fractures. And there are small differences in the detail between the different guidelines, but these differences probably have little effect on which women will actually be eligible and able to have treatment. And really importantly, Romosozumab can be used as the first treatment. So we'll get the really maximum benefit from its use. But based on the research studies, it should be avoided in women who've had a previous heart attack or a previous stroke. So I think my time is running out. So I'm going to stop here and summarize by reminding you that bone loss and osteoporosis are due to changes in the normal bone turnover process, that we have a range of effective treatments that can reverse these changes, either preventing bone breakdown, building new bone, or even combining both effects. And I hope that I've answered some of your questions and shown you that having an understanding of how our treatments work helps us to advise on the best option for each person. And look forward to hearing the discussion and answering some questions. Thank you.
Lovely. Thank you, Dr. Peel. That was a fantastic overview. Thank you so much for that. So it's great, by the way, seeing all of your questions that you've been popping in the Q&A box. So thank you for those. We are watching very carefully. And as I said, at the end, when we have our panel Q&A, we'll be posing some of those to Dr. Peel and Dr. Paskins. But for now, we have a few questions that were pre-submitted in advance by some of our members, which we've selected some of the most common ones. So question number one is from Roberta and Jean. And they ask, how many times can you have a 3-year course of zoledronic acid?
Right. Well, thanks, Roberta and Jean. That's an interesting question, and we've got quite a lot of information about how long treatments work for from research studies. And we know that some treatments can be paused every few years to give our bones a bit of a, sometimes called a drug holiday. So with zoledronate, after 3 years on treatment, many people can safely stop treatment for 2 or 3 years, sometimes longer. But we know that there are some people who are still at quite high risk of fracture who'd benefit from carrying on for a further 3 years and having 6 treatments in total. And that includes people who have more severe osteoporosis and who still have low bone density at the end of the first 3 years. It includes older people, those who have had previous spine or hip fractures, and those people who fractured during the first 3 years on treatment. So in those groups, we know that people can safely and effectively have up to 6 treatments, either all in one go or with a pause in the middle. What is less clear is whether people benefit from having more treatment after that. So the research studies have looked to see whether giving an extra 3 years, so 9 infusions in total, gives extra benefit, and that's really not clear. So it probably makes little difference to go beyond 6 treatments. And because zoledronate stays in the bone for a long time, it probably then stays there in the background working away for a good while longer.
Thank you, Dr. Peel. So our second question that was pre-submitted is from Margaret, and she asks, why is your first Denosumab injection usually given in hospital, and then after that you go to your GP practice? Is it okay? Why is it okay to have the follow-on injections there?
Yeah, it's an interesting question, and it's really down to sort of local guidance and agreement and familiarity with the treatment. So in some places, GPs are happy to start Denosumab treatment and give it independently. But as you say, Margaret, a lot of people end up having their first injection at the hospital, usually introduced by a specialist. And then after that, if the treatment is well tolerated, isn't causing any problems, then we'll often ask the GP to carry on giving the injections every 6 months, as much as anything from a convenience perspective, that the GP surgery is often much more accessible than going to your local hospital, especially as some people have to travel a long way for that. And the way that it's done is we have what we call shared care agreements. So if the first injection is straightforward, then the GPs are happy to take over the treatment and the monitoring, the regular blood tests that are needed. There are a small number of people who are probably more at risk of the adverse effects from Denosumab, and the one which we worry about the most is the injection causing a drop in the calcium levels, and that can be a problem, particularly if somebody's not got very good kidney function, and so there are some people like that who need to be monitored a bit more carefully, and sometimes we carry on treating people like that through the hospital. But sometimes we carry on treating people in the hospital just because the GP doesn't have the right arrangements in place to take over the treatment more locally. So
thank you.
Down a bit to chance.
Makes a lot of sense. Thank you very much. Well, thank you so much, Dr. Peel. That's all we've got time for the questions just now. And I'm going to hand it back over to Sarah to introduce our next speaker.
Thank you.
Thanks, Rose. So I'm delighted for our follow-on talk to introduce to you Dr. Zoe Paskins. Zoe is a consultant rheumatologist, and also just to mention that she is doing what I think is some quite groundbreaking research at Keele University, which is all about improving communication with patients and supporting good decision-making around medications. So she's going to be talking to you about how are those decisions made about who needs a drug treatment, and really importantly, how you can get involved in that process. So over to you, Zoe.
Thank you, Sarah. I hope you can see my slides. Is that, yeah, brilliant. Okay, so thanks very much. It's a real pleasure to be able to speak to you all today, and I do hope that I can help some of you, particularly those in the poll who said that you had some uncertainty about medicines at the beginning. So hopefully this will help a little bit. Okay. So what I'm going to cover over the next 10 or 15 minutes or so are really 3 areas. Briefly, how health professionals decide who should be offered a drug treatment, And secondly, how health professionals decide which drug treatment to offer. And I'll just touch on that very briefly, because I think Dr. Peel's already discussed that really nicely. And then the most of what I'm going to talk about really is helping you to consider choices and make decisions about medicines, and some of the things and considerations to think about. So the first question is, how do health professionals decide who should be offered a drug treatment? So how do they decide when to sort of start that conversation or to offer a medicine? So many of you on this call will be familiar with a bone density scan or a DEXA scan, which is what we currently use to diagnose osteoporosis. But it's really important, and probably one of the most important take-home messages from this talk I'm going to give, that bone density doesn't tell us everything about your chance of breaking a bone. It's just one part of fracture risk. So why am I saying that? Well, we observe in our clinical practice all the time that we'll have two patients who have the same bone density results, one of which may break lots of bones and appear to have very fragile bones, and somebody else who won't break any bones at all. So we know that bone density doesn't tell us everything about our susceptibility to breaking a bone. So you've heard in the talk before about how sort of complicated and nuanced our bones are, and all the things that are going on inside the bone. And the scans give us an idea of bone strength, but they don't tell us everything about the quality of the bone or what's going on inside the bone. We also know that there are other things about us that are risk factors for breaking a bone that are not necessarily related to bone density. So, for example, in the example I gave of somebody, two people who have the same bone density and one breaks several bones and the other doesn't, it may be that the person who breaks bones has other risk factors. So, for example, maybe they smoke. Maybe they drink more than recommended amounts of alcohol, which can weaken the bone. Maybe they have a strong family history, because we know that there are genetic factors that increase our susceptibility. In fact, we also know that just even breaking one bone is an important risk factor that increases your risk of breaking another bone. And age, of course, is an important factor, as well as your weight and height. So what we can do is put all these kind of ingredients and risk factors together and do a fracture risk assessment. And this is a screenshot from something called the FRAX tool, which some of you may be aware of, which is for health professionals to use. And you can probably just about make up some of the small writing there, but you can see that you can put in an individual's age, sex, weight and height, and some of their other risk factors, like smoking, alcohol, use of steroids, other medical conditions, and then you can come up with an estimate or a prediction of their chance of breaking a bone over the next 10 years. And this is really what drives treatment decisions. It's the overall risk rather than just focusing on the bone density on its own. You can include bone density as part of this fracture risk assessment. So it's part of the jigsaw, part of the picture. Once we've done a risk assessment, how do we then decide? Well, Nicky mentioned some national guidance earlier. She talked about NICE, which is the National Institute for Health and Care Excellence, which you may have heard of. It's a sort of government body. There's also other national bodies that make clinical recommendations for health professionals in Scotland and in the UK. And these guidance help clinicians make decisions. And so they might say, for example, that people with certain characteristics should be offered treatment. So, for example, the most common scenario there is people over a certain age, because age is an important predictor of fracture, who have already had one osteoporotic type fracture, such as a hip or spine fracture. It might also say that people on particular doses of steroid tablets should have osteoporosis medicine discussed or recommended. And then other than that, other than the list of certain characteristics, we use what's called a threshold. So a line is when we calculate your fracture risk, does it fall over a particular line or threshold? So we can plot fracture risk, and that FRAX website, which I just showed you on the slide before, links to this, this kind of image. And you can see at the bottom of this graph is age, and at the going along the vertical axis there is your chance of breaking a bone in percentage points over the next 10 years. And the cross there in the yellow section is the individual's fracture risk who we've just measured. So this is an approximately 80-year-old individual who's got just over a 20% chance over 10 years of breaking a bone. And if when we do this risk, that cross falls into the red section, either of the two red sections, or in the yellow section above that middle line, then it's recommended to health professionals that they have that discussion with patients or with the person in front of them about osteoporosis medicines. So I hope that helps sort of distinguish how we make those very early decisions about who to have these discussions with. The next question, which I'm just going to touch on briefly because Dr. Peel's already talked about it, is how health professionals decide which drug treatment to offer. And you've already heard a really detailed, nice explanation about the different sorts of medicine. And again, clinical guidelines help us here and give us some pointers. So I think the first thing your health professional might think about is the clinical effectiveness. So which of the medicines might be best for you? Some of the medicines are different in the extent to which they lower fracture risk at different sites. So some of them are better at lowering the chance of spinal fractures, for example, or hip fractures. And so depending on what risk is more important for you, that might factor into the decision making. The health professional will also think about the suitability of medicines for you and your other health problems and maybe your preferences if they know them already. So, for example, if you have significant indigestion or a problem with your gullet or swallowing, they might choose not to recommend the weekly bisphosphonate that Dr. Peel talks about. Cost effectiveness does factor in. I often get asked about this, but really that probably only influences our choices of the most expensive medicines, as I think Dr. Peel's already alluded to, which are mainly the sort of bone building anabolic medicines, teriparatide and Romosozumab. And then occasionally there's issues with availability of medicine. So we're lucky that this isn't too much of a problem. Of course, availability of HRT has been in the news a lot recently, but by and large, we don't generally have a problem with availability of the medicines. So moving on now, we've talked about how health professionals make decisions. And now what about you and you making decisions and choices? Well, I think it's helpful to think about three questions when you're thinking about medicine. So the first is, what will this medicine achieve for me? So I suppose in shorthand, that's what are the benefits, but it's, how is this medicine really relevant to me? How does it help me meet my goals? Next is, what are the possible downsides? So the risks or side effects. And the last important issue is what's involved and what will I need to do and what are the kind of practical steps involved in taking the medicine. So I'm just going to think about these three questions in a little bit more detail. So again, Dr. Peel's already talked about this, but I just want to enlarge on it a bit. And I'm generalising here across osteoporosis medicines as a whole. I haven't gone into the specific different ones, but there's a lot of generalisable points to think about here. So what does osteoporosis medicine actually achieve? Well, it strengthens the bone and it lowers your chance of a future fracture or broken bone. And importantly, when you're thinking about your chance of a future fracture, it's important to think about spine fractures or spinal compression fractures, because these can happen without a fall and without you realising it. So you might be aware of people with osteoporosis who've got a curved spine, or what used to be called a sort of dowager's hump, and that is a consequence of having spinal compression fractures. So by definition, if medicines lower your chance of future fracture, then that hand in hand is also that the medicine is increasing the chance of your spine being protected from those changes over time. The medicine works silently in the background, which means, unfortunately, it doesn't make you feel better. Even if your bones are stronger, it doesn't mean you're going to feel stronger, and they don't help with pain. As we've heard, some of the medicines also build bone, which means that you can have improvements in your bone density. But again, this isn't something that you will feel necessarily. And really importantly, the benefits are only achieved over time, meaning taking the medicine is a medium to long-term commitment. So you can see my piggy bank here. So my analogy here is it's like saving up in your bone bank. And if you were saving up for a holiday and you only saved for a couple of months, you'd be disappointed when you went to your piggy bank and you'd found that there wasn't enough for you to go on holiday. And it's the same with osteoporosis medicines, really, that really just taking them for a couple of months is not going to make any difference. And it's really that long-term sort of commitment that's needed to get the changes inside the bone. So next, what are the possible downsides? So the risks or the side effects. So again, I am generalizing here, but these are the sort of things that people are most commonly discussed. So the most common side effects with the tablets are indigestion or acid reflux. And also a number of people sometimes also get muscle aches and pains. And in fact, aches and pains can be experienced with a lot of the injection medicines as well. But the good news about this is that we can lower the chance of having indigestion or acid reflux if you take the tablets by having lots of water with the medicine and making sure that you stay upright after you've had it. And secondly, in terms of the muscle aches and pains, they usually resolve after you've been taking the medicine for a few weeks or so. So if you can, it's worth sticking with it. I can see there's already lots of questions and things in the chat about some of the rare possible risks, and particularly the jawbone problem, which is also called osteonecrosis of the jaw. I can't say it myself. Now, this problem is a problem of the bone of the jaw healing, usually after you've had a dental extraction. So it's quite a very specific problem. And you can lower the chance of that happening if you've got good dental hygiene and you have regular reviews with your dentist. A second very rare possible risk is having an unusual thigh bone break, which is related to the medicine rather than osteoporosis. And again, we can lower the chance of this happening. So you and your health professional will sort of work together. And we know that if people have appropriate pauses in their treatment, as Dr. Peel described earlier, then this is less likely to happen. And then finally, the question to think about when you're decision making is what's involved? What do I need to do? What are the practical steps? And again, I'm not answering these questions necessarily, but I'm giving you some things to think about here. So if it's tablets, how is it taken? So the most common weekly tablet for osteoporosis does need to be taken in quite a specific way. First thing in the morning on an empty stomach. And you need to wait for half an hour before you have your other medicines and something to eat. And the reason for that is that the medicine is best taken into the body on an empty stomach, so it gives it the best chance of working. If you're being offered injections, you can think about where will it be given? And I don't just mean where in the body, although that's a good point as well. So is it given in your tummy or your thigh, which usually subcutaneous injections are, but also what location? Can you have the injection at home, or will it be an outpatient or a day case unit, or perhaps a clinic closer to home? Some of the osteoporosis injections can be given by self-injection. So that will be something to consider. We want to think about how often the medicine is. And for some of the injection treatments particularly, sometimes monitoring blood tests are needed before and sometimes afterwards. So it's worth thinking about the steps involved in arranging those and how much kind of work that would be for you to do. You might want to think about how long treatment is for and when you will be reviewed and how you know the medicine is working. And this is a particular difficult question. So I've got an extra slide just to enlarge on this a little bit. So the important thing to say about this is there's no simple answer to this question, to knowing whether the medicine is working or not, because it works inside the bone. So we can't easily see it working. We need to take reassurance from all the research and clinical trials of these medicines with thousands of people that have clearly shown that they do lower fracture risk. So some of this we have to sort of take as a given. But having said that, your health professional uses a range of evidence to kind of make judgments about whether the medicine is effective or not. And it may include the following. So the first one is repeat bone density scans. There is no national agreement or international agreement for that matter on when these should be done. And so it will really vary very much according to local pathways and protocols. The other important thing to say about having repeat bone density scans is how we interpret the result. Now, bone density goes down over time. If we do nothing, unfortunately, over the age of 30 or so, we expect it to be going down with every year. So that means that bone density that just stays the same or even drops but just a little bit, that may be a positive response because it may be better than what we would expect if we do nothing. Your health professional might consider your fracture history. Now, importantly, none of the medicines come with a guarantee that they'll prevent fracture or you won't have a broken bone on them. They lower your risk. But clearly, if you have lots of broken bones or very serious broken bones on treatment, that might prompt a review of your treatment. And your clinician might want to look at your spine to see if there are any sort of hidden or undiagnosed spinal compression fractures to inform that decision making. And then finally, just to note that there are some specialist blood tests which measure what's going on inside the bone and the activity of the cells that Dr. Peel was talking about. But these aren't widely available. And again, the part of the reason for that is a bit like bone density scans. There isn't a clear international or national agreement on when these should be done or how we should interpret them, but they can be helpful in some situations. So going back to helping you to make decisions, we've talked about these 3 questions, and you might feel that you've got information about these 3 questions, but think, gosh, it's all just a jumble of information and I still don't know what to do. So I've got 3 tips for you if you do still feel uncertain about what you want to do. So the first one is to think about what matters to you or worries you most. What are you most concerned about? Does maintaining your independence over time, protecting your spine really concern you? Or are actually you really, really worried about these side effects? What of those things is probably going to keep you awake at night the most? That can be a helpful thing to think about. Second, you can try a bit of a thought experiment where you kind of project forward in time and think about, okay, if I made this decision, so say you make a decision not to have medicine, and then you suffered a spinal compression fracture in 3 years' time, how would that make you feel? And sometimes that can be helpful as well. And lastly, and this doesn't help for everybody, but for some people, it can help to try and compare the numbers and think about the chance of benefit versus the chance of harm. So I'm just going to talk you through an example of that. So this is an image from a decision support tool that we've developed at Keel. It's unfortunately not widely available at the moment, but it hopefully will be soon. And these sort of images are individualized. So this doesn't necessarily, what I'm going to just describe in a moment isn't necessarily relevant to you. It's just a case example, okay? So this graph or this image has been created for somebody who's got what we call a 30% chance of breaking a bone over 10 years or a 3 in 10 chance of breaking a bone. And what we can see with this graph is that this shows us 1,000 small people, okay? You can just about make out their sort of head and shoulders. And so what I would say, if I'd created this graph about you in particular, I would say, okay, if I had 1,000 people in front of me like you who took this medicine, what we would see is that in the dark green there, 100 of those 1,000 people would benefit from having the medicine. They would avoid breaking a bone. They'd avoid having an osteoporotic fracture because of the medicine that they were taking. And then what we can also see is the one little person in purple right at the top left-hand side. And that is if there are 1,000 people like you, one of those 1,000 people would have one of those rare side effects that I was talking about. So like the jawbone issue or the unusual thigh bone break. So that means that if 1,000 people like you took the medicine for a 5-year period, for example, one person would have a long-term issue. but that means 999 people of those 1,000 wouldn't. And you can also see from this graph that therefore your chance of benefiting from the medicine, so the people in dark green, versus your chance of being harmed by it, they're about 100 times more likely to be benefited from the medicine rather than you are to be harmed. So I appreciate that not everybody likes numbers, and for some people those numbers won't be helpful, but it does help some people. Okay, so I'm going to wrap up there. So in summary, health professionals use clinical guidelines and risk thresholds to decide who to offer drug treatment to. And when making your decision about medicines, it might be helpful to think about what the medicine's achieving, what are the possible issues, what practical things do you have to do, and ultimately, what are you most concerned about and what matters to you most? Okay, thank you.
Thank you so much, Dr. Paskins, for that. It was really comprehensive. Thank you so much. And it's been really great seeing everybody's conversation going on in the chat as well, and people sharing their experiences. So thank you. We just got one question that I'm going to pose to you from our members who submitted in advance. We got lots of variations on this question, and it's a really common question that we get asked here at the ROS. So Maureen asks, are lifestyle changes as good as taking a bone strengthening medication?
Well, yeah, thank you, Maureen. I'm really glad that that question's been asked, because of course we're totally focusing on medicines for the purposes of this webinar. But of course, the lifestyle changes around keeping active, thinking about your diet and nutrition, avoiding excess alcohol and smoking and things like that are also incredibly important. So I would emphasize that, and I really think about the whole package of treatment rather than just medicines as a whole. Now, if we're thinking about the question, comparing medicines versus lifestyle changes, really we're comparing apples and pears, because we don't have the same information for those two treatment options, and so we can't really consider them as alternatives. I consider them all part of the same package. The reason why I'm saying that is because we know from, as I mentioned earlier, research trials with thousands of people that the drugs lower the chance of broken bones. We don't have that evidence for any lifestyle interventions. We know that it makes people healthier and it improves other health outcomes, and that some lifestyle interventions may have small improvements in bone density, but there isn't the research evidence to say that they lower the chance of fracture. So really, I don't view it as a sort of equal option, if that makes sense, but really a package of options together, the lifestyle and medicine together.
That's fantastic. Thank you so much for answering that question. So that's I think all we've got time for this session. So back to Sarah to introduce our final presentation. Thank you very much, Dr. Paskins.
Thanks, Rose. So we're now on to talk number 3. As I said before, Professor Armstrong wasn't able to join us today, but he has re-recorded his video presentation, which we're going to show you now. He's going to be discussing some of these current hot topics and questions, and I can see them all streaming through, and luckily some of them are going to be covered by him. But just to remind you that after the recording finishes, we'll be going on to pose the more specific questions to both the doctors who are here tonight. So here we go, talk 3 with Professor Armstrong.
Good evening, my name is David Armstrong. I am a consultant rheumatologist in Altnagelvin Hospital in Northern Ireland, where I run the Osteoporosis service. I'm also a visiting professor at Ulster University, and I also in my spare time co-host the podcast Bone Up about osteoporosis with my colleague Dr Richie Abel from Imperial College. I'm really sorry I can't be with you in person live this evening. I really had intended to, and I'd enjoyed looking through the questions that had been sent in, but something else has just cropped up which is unavoidable. But I wanted to contribute as much as I could by making this video, just to deal with some of the sort of interesting questions that had come up and the issues that are current and are topical. So if I sound a little like an Oscar winner who's telling you that I unavoidably can't be with you tonight because I'm in Broadway, I can assure you that I'm not anywhere very exotic or exciting in making the video. So Sarah sent me on some of the questions that were common or had been asked, and I've had a chance to have a look at them. And I think they fall into some areas and some categories, so we can probably deal with more than one at once. There are a number of questions about the area of osteonecrosis of the jaw and about dental health and about having dental work done. And this is important because people worry about it, and it's certainly a common question I get asked at the clinic. The first thing to say, and I hope everyone you ask this says the same thing, is that osteonecrosis of the jaw is an extremely rare condition. It's actually so rare that it's difficult to get an exact figure for how often it occurs. I often tell people it occurs somewhere between 1 in 1,000 and 1 in 10,000 patients who take bisphosphonate, so it's an extremely unusual condition. It wasn't actually discovered in people taking bisphosphonates once a week for osteoporosis. It was sort of identified in patients who had cancer, rare types of bone and bone marrow cancer, and who were being given high doses of bisphosphonate by intravenous drip. And while you may be getting a bisphosphonate by an intravenous drip once a year, these patients were getting high doses and getting it every 10 or 12 weeks. So if you're a patient who has good dental hygiene and who has just osteoporosis and is receiving the drug just once a week as a tablet, the chances of you developing this condition are extremely small. And indeed, many of the references and many of the photographs you might see on the internet are not of people who had osteoporosis, but are people who had, as I say, rare types of bone cancer and were getting high doses of the drug by the drip. What is osteonecrosis of the jaw? Well, it's a tiny spot of inflammation and infection which occurs down at the bottom of the root, just where the root of the tooth joins onto the jaw. If you're having fillings done, then that doesn't affect the root of the tooth. If you're having crowns fixed, that doesn't affect the root of the tooth. We really only worry about dental work if the dentist is working at the root canal or is pulling the whole tooth out completely. The other important thing to say with osteonecrosis of the jaw is that it can be treated. Some people think if they get the condition, well then that's it, they have it for the rest of their life. But of course it can be treated. It can be treated with antibiotics, with painkillers, with certain types of dental work or other medicines. And the very small number of people who do develop the condition, it can be cured and it can go away again. In relation to that, and in relation to if the dentist did need to pull the teeth out, you can have your teeth removed if you're taking a bisphosphonate. Your dentist may want to refer you on to an orthodontist or to someone who's slightly more specialist, but there's no reason why you can't have the tooth removed if it needs removed if you're taking a bisphosphonate. It just takes a little more care and a little more precautions. But I've had a number of patients, in fact, I had a lady in just last week who had taken bisphosphonate for over 5 years and who successfully had a tooth removed. It healed up, it seemed quite quickly to her, and things continued as normal. So if your dentist says to you, I can't remove a tooth because you're on a bisphosphonate, that's not really in keeping with the up-to-date sort of medical opinion because you can have it removed. The other thing probably to emphasize, because this comes up from time to time, bisphosphonates do not damage your jaw. They do not damage the bone of your jaw or cause crumbling or weakness in the jaw. Bisphosphonates strengthen bone. Now, they strengthen bone in some parts of the body more than others, but they certainly do not weaken the bone in the jaw or cause crumbling of the jaw. They can just very, very slightly increase the risk of this rare inflammatory infective condition where the root joins onto the bone, but it's extremely rare, and the chances of you having a fracture if someone decides you've needed a bisphosphonate are always going to hugely exceed the risks of you developing this rare condition. So the take-home message really from the whole area is the condition's extremely rare. You can have your teeth removed and have dental work done if you're on a bisphosphonate, even if you need to go to maybe an orthodontist. And it's important to remember that bisphosphonates in themselves do not weaken or damage the jaw in any way. Another question that comes up quite often is what happens at the end of 10 years. People say, I've been told to stop my bisphosphonate after 10 years and I'm worried now that I'm not in any other treatment. People say, what happens if I fracture while I'm on a drug holiday? People ask, can I ever take a bisphosphonate again? And are generally concerned about this idea of having to stop a treatment, particularly at the 10-year mark where we say pretty much everyone needs to stop. There's a number of ways of looking at this. The first thing is to remember that if you take the drug for 10 years and then stop it, it actually continues to work in your bones for quite some time, probably for a number of years afterwards. So when you're sitting on the sofa 6 months after taking your last alendronic acid, the medicine is actually still in your bones and it's continuing to work. So while you may have stopped taking the tablet, you haven't actually stopped receiving treatment with the medicine. It continues for quite a number of years. The second thing to remember is if you've stopped after 10 years, that your bones are actually benefiting from you stopping taking the tablet, because the little cells called osteoclasts, which generally remove bone, and they tend to be overactive, particularly after the menopause, and remove too much bone. So you take the medicine to slow down their function, remove less bone. They do have one important function, and that is that they heal things called microfractures, little tiny hairline fractures that occur in stressed areas of the bone. And if you stop taking the tablet, then the osteoclasts have a chance to start to work and to repair those little hairline fractures. And therefore, probably the best way of thinking about it is when you're on your holiday, your bones are getting refreshed. The medicine's still working in the background, but the osteoclasts are starting to repair some of those areas of bone that maybe weren't just as good quality, had microfractures in them. So again, it's not as if nothing's happening. The bone is actually refreshing itself and the bone is becoming more healthy during that period of time. And of course, there's other things you can do, and this is maybe the third thing to think about with this. It's not as if you're not in any treatment, but you can do other things to help your bones. So you can ensure you have good intake of calcium and vitamin D. We're more focused now on getting a good intake of protein as well, because bones are made up substantially of protein, so make sure you get a good protein intake. It's a really good time to think about exercise. We're always encouraging patients now that exercise is good for your bones, just as it's good for your muscles. Have a look at the Royal Osteoporosis Society website. Have a look at the Strong, Steady, Straight document. You may wish to walk, you may wish to dance, you may wish to go to the gym and do resistance training. There's all sorts of things can be done, and lots of other things in between. There's lots of good information there, and that's something you can do for your bones. And there's lots of exciting research now, even for older people, even for people who have suffered vertebral fractures, that you can go to the gym, you can do exercise, even involving light weights sometimes, and that you will make your bones stronger and that you will reduce risk of further fractures. So really, the time after 10 years when you're on a drug pause or a drug holiday, it's not as if you're receiving no treatment. The treatment continues to work in the background. It's not as if your bones are getting worse. Your bones are actually refreshing themselves and healing these sort of tiny fractures, even though you're sitting on the sofa. Let's say you're not at the sofa. Let's say you're at the gym doing resistance training. Your bones are refreshing themselves and getting stronger and getting better during that period of time. And there's lots of other things you can do with exercise, with diet, to keep your bones healthy. There's probably a small number of people, and I see these people from time to time, that they have a very high fracture risk, or they've just fractured, or they have very, very low bone density. And for those people, I will want to move them on immediately to another treatment, often to a bone building or anabolic injection. But in general, that's quite a small number. And most people, as I say, will benefit from just having a pause after 10 years, and their bones will actually refresh and get better and get healthier during that period, rather than the concept that they're getting weaker and that you're not receiving any treatment. The other question that comes up, and that Sarah has passed on to me, and there are a number of questions from different people all sort of in this area, and I know it's something that one of my colleagues has probably touched on earlier in the evening, so I don't want to repeat, but that is the question: how do I know that the treatment's working? How do I know that taking this medication or giving myself the injections is actually good for me? And the standard answer to that, or the answer that I hope medical students give me when they come to the clinic, is that there are three things we look at. Firstly, we ask, have you had any fractures? Because ultimately that's what we're here for. It's to prevent people fracturing. We might as well be called the Royal Society for Preventing People Having Fractures. And therefore, if you've been on a treatment for 5 years and you haven't broken any bones for that 5 years, then to some extent it has been successful, because that's the ultimate goal of all this. The second answer to that is we do a bone density scan or a DEXA scan. Now, I know availability of DEXA scanning is different in different parts of the country, but I think if you've had a scan done and you've been told you have low bone density and you've taken a tablet for 5 years, it's entirely reasonable to repeat that scan to know to what extent your bone has improved. If I see someone with high blood pressure and start a blood pressure lowering tablet, I'm going to want to check their blood pressure afterwards to see if it's better. And I think that's the same with the DEXA scan. Some people do actually see an improvement. In fact, many people see an improvement in their bone density, even taking bisphosphonates. I have to remind people, particularly older people sometimes, that without treatment, your bones get weaker every year. You lose 1 to 2% of bone density. So if I give you no treatment and repeated your DEXA scan in 5 years' time, without treatment it might be 10% lower. So if I repeat your scan and it's only 1 or 2% lower, then that's actually a net gain from the treatment you've taken. Most people, I must say, do see a small improvement, particularly in the early years of taking the medication. And finally, we sometimes use blood tests called bone turnover markers. The little osteoblast cells that build bone and the osteoclast cells that remove bone, they both produce enzymes as they work, and you can detect those enzymes in the blood or in the urine. And that gives us an idea sometimes just how well either the anti-resorptive medication, that's the medication that stops you losing bone, how well it's working, or the anabolic medication, the medication that builds bone. You can measure both of those as blood tests. They're not available everywhere and they're not necessary for everyone, but they're certainly another way of telling how well the drugs are working. It's probably worthwhile pointing out in terms of a fracture. We often say if you fractured on treatment, that's a treatment failure. And of course it is to some extent, because we're giving you medicine in the hope that you will not suffer a fracture. But I think it's important when we explain to people at the start of treatment what we're doing. I think it's wrong to say, I'm giving you this tablet and it will prevent you from fracturing a bone. It will certainly make it a lot less likely that you will fracture a bone, but I don't think we can promise people that it will entirely stop you fracturing, because it clearly won't. And perhaps a better way of explaining it is, if we take thousands of women in your position with the same age and the same history, and we follow them up for 5 years, if 100 of those women were going to break a bone, and instead they then took this tablet, perhaps only 50 of those women would break a bone. It would halve the risk of breaking a bone. Now, I think if you explain to people that at the start of the medicine, taking the medicine, most people would say, yep, I'll have that medication because that sounds good, that improves my chances. But they'll understand that even if you take it properly and correctly and take it every week and right to the end of the 5 years, unfortunately some people still will break a bone. Doesn't mean the medicine hasn't worked, doesn't mean your bone's not more dense. It just means that you're perhaps unlucky and you've fallen into those group of people who still suffer a fracture. You may have suffered more fractures without the treatment. Your bone will almost certainly be denser and stronger in that sense with the treatment. But it's probably fair that we level with people at the start and say this treatment reduces your risk of fracture but does not completely obliterate it. And for that reason, if someone has been on treatment for, let's say, 4 or 5 years and they come to see me and they've recently suffered a fracture, for some people I will say the treatment hasn't worked as well as it might. Let's consider a different treatment, perhaps Denosumab, perhaps teriparatide. But for some people I will say, I think this is still the best treatment for you. It has worked well in terms of strengthening your bone. The alternatives are perhaps not suitable, and I advise to continue with it for a little longer. Ultimately, at a population level, we know taking bisphosphonates reduces the risk of fracture, and that's why we prescribe it for people. But it's important to be in contact with some health professional, because people do like to know that their medication is working, and it's good, as I say, to be reviewed, to be followed up. And I think for almost all patients, certainly a repeat DEXA scan is a useful thing to have. I've covered quite a few of the questions I've been given here. I'm just over my time, so what I will do is hand you back to the live program this evening. It's been very nice to talk to you, and I hope next time, if I'm invited back, we'll actually be able to get some live interaction. So, good evening.
Well, thank you to Professor Armstrong in his absence. Lots and lots of detail there, which I hope you found useful. And we're now going to move on to the panel session. So can I invite the speakers, and Rose, I see, has joined us, to come back so we're all together again. As a reminder, do continue to add your questions into the Q&A box. I have to say, I have been reading all of them. There are a huge number, but I'm going to try really hard to select what I think are the most perhaps relevant questions for you all and putting them to the panel. We have got about 20 minutes. I'm going to be firing those questions a bit, so I will kind of ask the speakers to try and keep their answers fairly short if they can. Right, are we all ready? And I shall start to send you over some questions from my list. There are quite a few questions, not only that have come through now, but came through earlier about hormone replacement therapy. So I am going to just ask perhaps Dr. Peel to start with to tell us a little bit more about HRT as a treatment. The questions that we've got, there is one here by someone who said they had to stop teriparatide because which they were taking following multiple spinal fractures, and are now considering moving on to an HRT, an estrogel, and we just want to know, is that a reasonable treatment, and will it be effective?
It's absolutely a sensible treatment to consider. HRT works on the osteoclast cells a lot like the bisphosphonates and denosumab. It's an effective treatment to prevent bone loss, and we know that it reduces the risk of fractures. It's a particularly good choice for women who have an early menopause, and women who are in the first few years after the menopause and might be having menopausal symptoms. So when we use HRT, we usually start it in women up to the age of about 60. But that's not a hard and fast rule. And if treatment options are limited, then the really important thing is considering all the risks and benefits. So like anything else, HRT can have some side effects and adverse effects. And the important thing is to talk to your healthcare professional about the risk of benefits and risks in just the way that Zoe was describing earlier. I
was going to ask you another quick question around HRT. Somebody is asking, I'm in my 70s, I'd really like to try it. Will it be effective, and is it safe for me?
It will certainly be effective. There's no age cutoff at which HRT doesn't work. As I say, we usually think about starting HRT up until about the age of 60. But if none of the other options are suitable, then there's no reason at all why HRT shouldn't be considered, so long as you don't have contraindications to its use. People who are a long time after their menopause may be a little bit more likely to get side effects, particularly when they first start on hormone treatment, because they've not been used to having hormones for quite a long time. But there's certainly no reason to think that it wouldn't be a helpful treatment from the perspective of osteoporosis. Thank you,
that's great. Here one perhaps for Dr. Paskins. We've got quite a few questions about Denosumab. I know it raises some issues. So some questions that have just come through today, I don't know if you could cover them. One is about, can men have Denosumab? One is, well, there are two or three actually saying what happens when I stop it. I'm worried. What are the consequences? And what, how can I stop it if I need to? Somebody's saying I get side effects of the Denosumab. I want to stop it. I can't take bisphosphonate. So what's the future for me?
Okay, so the men one is easy. Yes, it's licensed for use in men. In terms of stopping it, there's a few things to say there. So firstly, we heard that caution from Dr. Peel around what can happen if we stop it, in terms of it slightly increasing your risk of having that increased turnover and fracture. It's worthwhile saying that it depends how long you've been on treatment and what your baseline risk is as to how much of a concern and a worry that is. So if you've been on treatment, for example, for less than 5 years, or if you've got a relatively low baseline risk, that may be less of a concern. So that may reassure some people who are anxious about stopping. The second thing to say is, do you need to stop? I've seen some comments in the chat which imply people are having a course of it, and actually, you know, we don't recommend that it is stopped. We've got 10 years of research evidence that it's safe, which is equivalent to most other medicines that we prescribe lifelong. So you know, does it really need to be? I appreciate for some people it might be, but you know, does it need stopping? And then the third thing I think to say is if it does need to be stopped, there are strategies to kind of to stop it that you can discuss with your health professional. There's a number of different options for other medicines that could be started to kind of cover that period where it is stopped. So lots of things to consider. That's the shortest answer I can do, Sarah. Will that do? No,
that's great. Another question, you haven't mentioned strontium ranelate much. Could you just tell us, is it a useful treatment? And why are we not hearing so much about it?
Is that for me?
Yeah, let's go with you again.
Yeah, we do use it, but very rarely, I would say, given all the other options that we have available to us. It is an effective treatment, but like everything else, it's got side effects and restrictions on who it can be used in because of the side effects, particularly relating to safety to do with a risk of blood clots and heart attacks and strokes. And that does place quite a lot of restrictions on who it's suitable for. So for that reason, it's really quite a narrow group of people that we might consider in it. But it is effective, but that's probably why we haven't particularly emphasised it today.
Thank you. Question for Dr. Peel. Why can't I have Romosozumab if I had a stroke?
The research studies showed that of the 3 research studies which were done before Romosozumab became approved, in one of the studies there was an increased risk of cardiovascular disease, including strokes and heart attacks. Now, what's not completely clear is whether that was down to the Romosozumab or whether it possibly could be that the people in that study who weren't taking Romosozumab were the ones who were treated with alendronate. And some people believe that the alendronate might have given a bit of protection against having heart attacks and strokes. And that's been talked about because in the other 2 big studies, there wasn't any increase. But enough of a concern was raised that at this point in time, with it being a reasonably new treatment, we obviously have to take seriously the observations from the studies. So at least for the time being, the recommendation is that if somebody's had strokes or heart attacks, that it probably isn't the best treatment for them.
Okay, lovely. And another question here to either of you, really. Pre-menopausal women, we hear a lot about post-menopausal women or younger men even. What treatments are right for them and when might you use them? And if not, why not?
Okay, well, shall I take that one? So I think for pre-menopausal people, again, number of things to say. First thing is we have less research because most of the research trials of the medicines have been in postmenopausal women. There's very few research studies of younger women. So so that's the first thing to say. Second thing is in younger people, there's often, not always, but often some contributing cause to having osteoporosis or fracture risk. And it might be appropriate to address that first before jumping in with the medicine. So it might be about optimizing weight in people who are underweight, for example, or for people with something like celiac disease, which I've seen mentioned in the chat, it might be appropriate to trying diet first. So there might be something else to try first. And the other thing to say about premenopausal women is that I talked about all the factors that influence your risk of breaking a bone, and probably the strongest one is age. So even if you have low bone density when you are younger, your absolute fracture risk is probably still low because of your age. So it may not be that there's so much enthusiasm as to leap in with the medicine and perhaps try some other approaches first.
Thank you. how long can you take a bisphosphonate for? What is the sort of maximum? People worrying about that, but also people are worrying about that they've been told they can only take it for 5 years. So the more quite a lot of duration questions, which I know Professor Armstrong covered, but I wondered if any more comments about Dr. Peel. I don't know whether you want to pick that up.
So alendronate, a little bit as I talked about with zoledronate earlier, we like to reassess fracture risk after a few years on treatment. So in the case of alendronate, then we would usually do that reassessment at 5 years. But there are some people when we're first starting treatment who are clearly at higher risk of fracture. And right at the outset, we can predict that they're likely to benefit from staying on treatment for longer. And the research studies for alendronate give us good evidence about the treatment continuing to be effective and safe for up to 10 years. We don't have longer term research data after that, but decisions about continuing treatment beyond 10 years of a bisphosphonate tablet or beyond 6 years with zoledronate need to be made on an individual basis. So, we would need to assess that person's risk of fracture and balance the risks and benefits of giving longer term treatment, bearing in mind that things all become a bit less certain when we have less data to base those decisions on.
Lovely, thank you. There's one other question that's just come in, which is saying, I really reacted badly to the alendronic acid. I think she's talking about aching muscles and so on. Will it be the same when I go on to zoledronate? I think this is a common thing we get asked, which is sort of in there. Once it's in there, it can't be removed. So, I'm worried about giving it a go. So I think Dr. Paskins said usually that kind of pain goes away, but this person obviously had a longer term problem with muscle pain.
I always warn somebody that if they've had lots of aches and pains with a bisphosphonate tablet, then if they switch to zoledronate infusions, they may well get the same aches and pains in response to the treatment, because it's not an uncommon thing to happen the first time people have the infusion. We can make it much less likely that it'll happen, and we can make it less severe by giving treatment like paracetamol at the sort of just before treatment, and advise people to carry on taking it for 24, 48 hours after the infusion. But the other thing which I always reassure people about is that although the treatment carries on working for a year or more, that doesn't mean that it's sort of in the system and likely to cause long-term side effects. So the zoledronate after the infusion, it only stays in the bloodstream for hours or a day or two at most. And everything that isn't taken up by the bone is then excreted through the kidneys. And so there's no reason to think that the effects will be any longer lasting after having the infusion than they would be after taking the weekly tablet.
Okay, thank you. A question here for Dr. Paskins. Somebody who thinks they've probably got osteoporosis, or certainly something to do with having been on prednisolone, so a steroid, but is sort of wondering, is the drug going to be enough to sort of counteract the effects of the steroids if they're continuing to have to take them?
Yeah, so I think the short answer is yes. I mean, there's good evidence that the osteoporosis medicines can sort of protect against steroid-induced osteoporosis. I suppose as a rheumatology doctor, I quite often have to use steroids in my practice. And if we know we have a person with osteoporosis, we always try and use the lowest possible dose and for the shortest duration and things. So obviously that's just sensible anyway. And I'm sure your health professionals will be doing that. But yeah, that's a short and succinct answer to that, Sarah.
Thank you. A little bit of a practical one here for either of you. Someone being rather confused about having to, this is taking bisphosphonate and needing to take it after they've got up, I think was the instruction. So a little bit of a clarity around, how you need to take it and why, in terms of being upright, standing after you've got up. Could you just give us a... I
need to take that one. So it needs to be taken first thing in the morning on an empty stomach, and then you wait for half an hour before having anything to eat and your other medicines. And the reason for that is that it's better taken into the body on an empty stomach. The other part of the instruction is to lower the chance of it causing indigestion or gullet problems. And so the other important part is to make sure that you stay upright after you've had it and to have lots of water with it. Now, by saying upright, it doesn't mean standing up. It could be sitting, but it just means don't go back to bed after you've had it and lie down.
That's great. Thank you. Now, I don't want to drag on too much about the ONJ because I think the osteonecrosis of the jaw was covered really well by Professor Armstrong, but we are still getting some questions in. So I just want to ask a couple of questions here. So one is about implants, which aren't mentioned once. We've certainly heard you certainly can have your teeth removed with precautions in some situations, but it's still a low risk. And people are asking about implants. There's a couple of questions. So is it possible to have an implant?
Yes, I think a lot of dentists, as has been mentioned in the questions in the chat, a lot of dentists are quite wary of bisphosphonates. And I think that's because of what David was talking about, that they don't really appreciate the much lower risk when bisphosphonates are being, and other treatments indeed, are being given for osteoporosis in comparison to the much bigger doses that are used in other scenarios like cancer treatment. There are some research studies, not big ones, but there's a little bit of information showing that implant surgery can be fine after somebody's been taking bisphosphonate treatment for a while. So it may not be easy to access, but providing there's really careful management after the implants to make sure that any risk of an infection is kept as low as possible, then there's every chance of it being successful.
Thank you. I wish we had longer because so many really good questions, but someone's asked quite an important question, I think, for either of you. Maybe it's for Dr. Paskins. Do I really have a choice? And I think this is quite an interesting one. It's around, actually it's the rheumatologist who decides that, and I can't even get to see a rheumatologist, is what someone else has said. So not being too cynical, but any comments there about people who see all these wonderful drugs but think, how am I, what's the choice? Is there really a choice for me?
Well, your first choice, if you're only offered one thing, is to take it or not take it. And then I think, do you have a choice in medicines? Up until very recently, I think there was a real sort of push just to try the tablets first. And then if that didn't suit you, then that would open up other options. But I think that's changing, to be honest, with the new NICE guidance that's come out. So if you have had a major fracture in the last 2 years and you have got osteoporosis on a bone density scan, then you absolutely do have a choice, or you will have a choice very soon, and it is reasonable to ask for a choice.
Okay, that's great. Thank you very much. I've got my eye slightly on the time, but can I ask one more question? What is severe osteoporosis? Someone's asking. You talked, I think, Dr. Peel, about severe. What do we mean by that?
Yes, I mean, it's a slightly technical definition, but the way in which it's used by NICE when they were looking at the treatment is, as Zoe's just suggested, a combination of osteoporosis on a DEXA scan together with what we call a major fracture. So that's a fracture affecting the spine, the hip, the upper arm, or the wrist. So that's the sort of official definition, but we often use it much more loosely than that and take into account the other risk factors that can increase or decrease people's risk of fracturing.
That's great, lovely. And I think we're going to have to stop now. I would just say, having looked at all these questions, there are many people asking questions about DEXA scanning, about a lot of the side effects, about vibration therapy. I would really encourage you to have a look at all our fact sheets, because we do cover quite a lot of that in our information. So I'm sorry we haven't got to it today, but search on our website, or if necessary, give us a call. So, well, all we've got time to talk for, and in fact, we're now at the end of the session, so don't go away quite yet. I want to say a huge thank you, first of all, to Dr. Peel, Dr. Paskins, and Professor Armstrong, when he listens back, for their time and their, expert contributions, which I know everyone has appreciated. And we just really hope that this session has really helped to build your understanding about medications, and that you perhaps feel a bit more supported when you're offered one, and feel that you can take part in that sort of decision-making process. Quick reminder from me before you go that you are going to get this short online survey that we mentioned. Evaluation, really important if we're going to improve these sessions in the future. So it's going to come around to an email. Please fill it in, and thank you, and goodbye to our speakers, but perhaps not goodbye to everyone else just yet, because few more words to say. Thank you.
Thank you. And we do, as Sarah said, really hope this session has been useful. Please fill in the evaluation. But before we go, we just wanted to quickly let you know about some of the other things that the Royal Osteoporosis Society can offer you in terms of some support. So first of all, I know that many of you are members who are on the session with us today. But for those who aren't, membership is a great way to keep up to date on news about osteoporosis and all of our information and support for just £2 a month by joining us. Then we also have a network of local support groups and regular information events where you can connect with others in your local area who are going through the same thing. We have a huge wealth, as Sarah mentioned, of information resources on our website, including videos and fact sheets and content to download and print at home. So please do check some of that out afterwards. And of course, we have our helpline, which is staffed by a team of specialist nurses who can give information and support all about osteoporosis. And please keep watching for the Bone Matters series to see what's coming up next in the programme. We've got lots of really informative and interesting information sessions coming up. And then finally, just to say that we do a lot more at the ROS than just offer support. So we campaign, we implement policy and practice, we support groundbreaking research, and of course raise funds so that we can be here for everyone affected by osteoporosis. And if you'd like to find out more about any of those things and to get involved with us, please visit our website, which is theros.org.uk. And I think that just leaves us to say thank you so much to everybody who's joined us today and been watching at home. It's really been quite incredible watching all of the comments and the conversations and the sharing of stories that's been going on in the chat. So thank you just very much, all of you, for joining and participating with us tonight.
Yeah, and thanks again from me and to all our speakers for their time. We hope to connect with you again very soon in the future at one of our future Bone Matters events. So goodbye from me too.
Goodbye. Thank you.